So many aspects of the immune system go wrong in multiple sclerosis. The details may differ between people with MS, and the immune response can change over a person's life. It all makes it hard for scientists to find biomarkers to diagnose MS and to tell how well different treatments are working for persons with the disease. Does this look familiar? This slide takes us into the brain and spinal cord of people with multiple sclerosis. It summarizes most of the problem-causing immune activity known so far and many of the targets of disease-modifying therapies. This image is often shown in presentations to astonish the audience with the mind-boggling complexity of the immunopathogenesis of MS. But what if we broke it down and looked at it step by step? The slide comes from Dr. Dhib-Jalbut at the Robert Wood Johnson Medical School in New Jersey. This year, he animated the slide to follow the immune cells and their disease-promoting activity step by step. Dr. Dhib-Jalbut worked with MSDF to provide this animation and narrates it himself for our audience. Keep an eye out for these key players, the inflammatory lymphocytes Th1 and Th17, as well as B cells and professional antigen-presenting cells, APCs.
This slide is a synthesis of our current understanding of the immunopathogenesis of MS. The belief is that MS is triggered by the peripheral activation of pro-inflammatory Th1 cells, Th17 cells, and B cells by myelin or microbial antigens presented by professional antigen-presenting cells and B cells. Activated lymphocytes upregulate adhesion molecules on their surface, such as VLA4, which binds to VCAM1 on the endothelial cells, resulting in their adherence to the blood-brain barrier. Activated lymphocytes secrete matrix metalloproteinases, which break down the blood-brain barrier matrix, resulting in their migration into the CNS. Chemokines released from inflammatory cells and astrocytes are believed to help in the recruitment and retention of pro-inflammatory cells within the brain. Pro-inflammatory lymphocytes within the CNS also undergo another level of activation by microglia. These pro-inflammatory Th1 cells in the CNS can now activate monocytes to mediate myelin and axonal injury. Soluble products from monocytes and microglia, such as nitric oxide and proteases, are believed to contribute to tissue damage. B cells activated in the periphery can access the CNS, differentiate into plasma cells, produce antibodies, and along with complement result in myelin damage. Another pro-inflammatory cell involved in MS is the Th17 cell. Those cells are activated in the periphery under the influence of cytokines such as IL-6, TGF-beta, and IL-23. Recent evidence suggests that migration of CCR6 expressing Th17 cells through the choroid plexus into the subarachnoid space represents the first wave of inflammation resulting in activated blood-brain barrier endothelial cells. Th17 cells can activate microglia and neutrophils in the brain, resulting in further inflammatory damage. There are also a number of other toxic mediators worth mentioning. For example, CD8 cytotoxic T cells can cause damage to oligodendrocytes. Glutamate released from microglia is also implicated in neuronal damage. EBV-infected meningeal B-cell follicles have been associated in some studies with disease progression. These processes are believed to be responsible for the inflammatory damage and disease progression. On the other hand, MS patients go into remission. T regulatory cells, including Th2 cells, TR1, Th3, and FOXP3 positive cells, are also generated in the periphery, access the central nervous system, and downregulate the inflammatory processes resulting in disease remission. This paradigm is consistent with the immunopathological observations made in MS and its animal model EAE. This paradigm is also consistent with the mechanisms of action of MS therapies, including the interferons, glutaminyl acetate, natalizumab, and the more recent immunomodulatory oral agents.